Where we are right now, we're between these kind of single-arm prospective trials where we have data, and we're all breathlessly awaiting kind of some of these large randomized control trials, including HIPITHO, which are coming down the line. We're looking for more insight into what we're doing and how we're doing it. And now there's something else. Now there's this concept of what kind of big data analytics are, which honestly, every other field has been using for decades to change the way we buy groceries and shop online and, fly from America to Europe. Now we're going to be able to do this here too. And that is so exciting because we're going to be able to do it in real time. I mean, when we talk about Truvada, at the time of our work with Real PE, this was 82 million patients, 400,000 patients with pulmonary embolism. And so we're looking at that entire patient experience. So that was step one. Then what we looked at is we looked at patients who had during their course of their care treatment with a device identified by a unique device identifier code. And so we focused in on two. We focused on the unique device identifier codes for the EKOS ultrasound assisted catheter directed thrombolysis catheter, which we refer to throughout the paper as ultrasound assisted catheter directed thrombolysis. And then the unique device identifier for the Inari FlowTriever device, which is one of the most commonly used devices in mechanical thrombectomy. And so when we refer to mechanical thrombectomy, we're looking directly at that Inari FlowTriever device. We started by pooling this data set and looking at who was being treated, and then also looking at what was happening in their near-term, short-term safety events. And really the most striking, the most powerful thing that we dove into was looking at bleeding. Because obviously we're talking about therapies in patients that are being anticoagulated, and as a result, patients that are at risk of bleed. And there was this question in the literature already where there's multiple different bleeding risk scores that are used across different trials. It's really impossible to try and compare those because you're looking at different treatment times and different patient populations. And we wanted to say, what's happening with bleeding in these patients who are putting on blood thinners? One of the things that we saw is we figured out that we could actually look directly at blood values. We were able to choose blood values from before the therapy and then look at hemoglobin values within 7 days of the actual therapy being delivered. That's a very hard, fixed endpoint. With mechanical thrombectomy devices, there was an increased risk across the 3 ways we looked at bleeding versus with ultrasound-directed catheter thrombolysis. So whether it was a hemoglobin drop by greater than 2 points, a hemoglobin drop by greater than 5 points, the need for a transfusion, or a billing and coding identification of a major bleed etiology, or a pooled version of that remodels the ISTH or the BARC3B bleeding criteria, there was more of that bleeding with mechanical thrombectomy than there was with ultrasound catheter-directed thrombolysis. And though some of us expected that, many of us probably would not. They might have expected that, any version of TPA would cause more bleeding. Whereas it's extremely biologically plausible that putting a 26 French sheath in someone that's on active anticoagulation would experience a bleed. Interestingly, intracranial hemorrhage, there was a difference between the two groups. But somewhat surprisingly, that risk of intracranial hemorrhage was higher on the mechanical thrombectomy side than it was on the ultrasound catheter-directed thrombolysis side. And people ask, why? Why can thrombectomy cause intracranial hemorrhage? We know, and we've seen in the published literature, and we reference it in Real PE, that there have been events in patients having paradoxical embolism during a thrombectomy procedure through a PFO. And the total risk of those events, we don't know. But it's been published. We also looked at length of stay in these patients. And interestingly, there's no difference in length of stay, which a lot of us that do a lot of PE work and do both therapies would not really be surprised by. Once we think about the course of a patient's care through, we don't really anticipate or expect a length of stay difference. Also, no difference in readmission, no difference in inpatient mortality between those groups. My hope, believing in this data, is that what it will do is it'll impact how people are using kind of their standard of care therapies for advanced treatment of PE. And we'll start seeing people believe some of the safety data, about trying to minimize bleeding through small catheters, delivering small doses of TPA over time. I think it really will be powerful in terms of impacting practice.